Hello and welcome to Hacking COVID-19. This is a short series put on by the BioHacking Village, Dying Society, and MedISAO. Today we have Ray Dorsey. He's a physician, and he will be talking about tips and tricks for telemedicine visits from a physician's perspective. So Ray, if you could introduce yourself and welcome.
Daniel, thank you very much for having me. My name is Ray Dorsey. I'm a neurologist at the University of Rochester, where I direct the Center for Health and Technology. Our vision is that anyone, anywhere can receive care and participate in research. And for the past 13 years, I've been connecting to patients with Parkinson's disease in nursing homes, and for the last 10 years, directly in their homes. I almost exclusively see my patients over telemedicine, so much so that I haven't been actually in a clinic since 2013. Telemedicine is a lot easier to do than most people realize, and I think many people are realizing it now. When we started doing this, 13 years ago, the technology was still relatively new, but even then, Skype was widely used to connect people who were geographically separate. And now it's used every day, and probably as we are speaking, physicians are using it to connect to patients. We use video conferencing software from Zoom. We have no financial interest in Zoom, unfortunately. And it's relatively easy to use. One nice thing that we have found is that we have a team of research assistants, that could be clinical coordinators, who set up patients for their first telemedicine visit. And they do that by simply emailing them a link to the software, walking them through the installation, and then once they're connected, they're set up to see a clinician. And on the day of their appointment, the time of their appointment, the coordinator connects to them a few minutes beforehand, make sure that they're teed up so they can be seen by the clinician. The visits that we do are very similar to what you would do in a clinical setting. We probably spend a little bit more time on the history and learn more about that, but we do a brief neurological exam, very similar to what someone would do in clinic. For people with Parkinson's disease, we look for tremor. We have them hold out their thumb and index finger and tap very fast because people with Parkinson's disease have slow movement. We have them cross their arms and stand up and walk, as people with Parkinson's disease have impaired gait. And we often, depending on the individual, might have their spouse adjust the camera so we can see them walking, for example, because most video visits are from the trunk up. We put together a video on how to do a telemedicine visit that's really oriented for Parkinson's disease, but can be readily extended for a wide range of other conditions, and we put that up for the Dying Society to share with you. It's also worth noting that the vast majority of the important information from a medical encounter comes from the history. Numerous studies have shown that 80% of a diagnosis is based on history, about 10% on the exam, about 10% on laboratory testing and imaging. So we spend a lot of time, and probably more time, on the history than we would do in a typical encounter. We do, as I mentioned before, do include an exam. The other thing is that what we lose on the exam, because there's certain elements of the exam that you can't do remotely. For example, in neurology, you can't test reflexes in somebody's home remotely. We more than make up for that in the social history. So we see people in their natural environment, and we see their friends and families, or lack thereof. We sometimes see them in various stages of dress and undress. We get a better sense of what their life is like and how their disease impacts them. So although the exam is compromised when doing it remotely, you end up learning a lot more about their social situation. And finally, perhaps most importantly, patients love it. Sometimes between 5 to 15 minutes in the visit, or maybe at the end of the visit, there's a sudden realization that they've been able to connect to a clinician that they generally like, and have been able to do so on their terms. The patient has come to them and seen them in their home instead of, sick patients coming, seeing healthy clinicians on our terms. And that's a fundamental transformation in the nature of the visit. And in addition, they're on much more equal footing. I'm sitting down, I'm 6'5", so I'm a tall guy, and I don't wear a white coat to my visits. And people aren't wearing a gown and aren't in a cold exam room when they're doing the visit. And so they're seeing me at an eye-to-eye level. We're both generally sitting down. And if they really don't like me, they can simply close their laptop or turn off their smartphone, and away I go. Haven't had that happen yet, thankfully. but they are much more empowered in these visits, and I think in some ways allows a deeper relationship to form. So in conclusion, telemedicine is relatively easy to do. Medicare and Center for Medicare and Medicaid Services have removed a lot of the financial barriers and even some of the licensing barriers to using telemedicine. Patients are getting increasingly aware about the benefits of telemedicine and gaining experience to using it. And we're hoping that the changes in widespread adoption that we're seeing in telemedicine today will stay with us as a silver lining after this pandemic passes.
Do you have any recommendations maybe for physicians that have never done telemedicine and now are being forced to, like any stumbling blocks or tips and tricks?
So to learn how to do telemedicine, I think you can follow the same advice that all medical students know and all residents know. See one, do one, teach one. So if you've never done a telemedicine visit, just watch a clinician, one of your colleagues who has. You'll quickly pick up on some of the important elements of it, including listening and eye contact. And then do one. And if you really are concerned, which most people probably aren't, you can have someone watch you do one, and then you'll soon be able to teach others how to do it. It's something the same as a traditional appointment. If anything, it puts a premium on being a good clinician because you have to listen more and observe more, talk less, and show less.
Recently, HHS has removed so I'm looking for like HIPAA restrictions on doing telemedicine at this time. Do you think that'll make it easier? Do you think there's going to be some issue when the restrictions go back in place, maybe with not using the right technology? Or do you think that we'll see more of this going into the future as people realize how easy it is?
So in the setting of the COVID pandemic, the Center for Medicare and Medicaid Services has adopted long overdue changes. Among those changes are reimbursing for telemedicine visits in the home for any condition by Medicare. Prior to this, Medicare has been the laggard in terms of adoption of telehealth. Until recently, they spent less than 0.1% of their budget on telemedicine visits. Now, any Medicare beneficiary in the country for any condition can receive care from any physician and a whole range of other clinicians can receive care for a whole range of conditions. That's because Medicare or CMS has also waived state licensing restrictions for Medicare and Medicaid beneficiaries. So those individuals can now receive care from any specialist regardless of geography. These are huge changes that many of individuals have dedicated decades of time and efforts to try to get them to change. And in the span of a week, in response to the COVID pandemic, these changes have been enacted. These are all temporary. It's really, really important that we push CMS and the government after the COVID pandemic passes to make these permanent so we can more fully realize the potential of telemedicine and enable anyone, anywhere to receive care.
And finally, do you have any recommendations for patients regarding telemedicine? Anything that maybe would make your life easier and life easier for the physicians that are going to be, again, thrust into this now?
I think patients need to be far more demanding, especially Medicare beneficiaries. Some of them have paid in for 50 years into Medicare, whose primary purpose was to guarantee access to health care at a time in 1965 when half of older individuals didn't have access to care. They should be the voice that ensures that Medicare doesn't turn back the clock on telemedicine to the pre-pandemic coverage and ensures that any Medicare beneficiary can receive care from any physician for any condition. They've paid in, it's their tax money, it's their tax dollars that are being spent, and they should be spent for their benefit and not for the benefit of, institutions or others that are seeking to restrict access to care.
It's really an honor to have, be able to have you on here and try and amplify this message. So.
Thanks very much.
All right, thanks, Rick. Bye.
Bye-bye.